ये इसमें ना हाँ ये
एक
हमारे
बार इनसे पूछ लेते हैं कि हाँ जो दूसरा डेलीगेट लिंक है, they would know how many have already logged in.
हाँ
Dr. Prachi,
Yes,
Dr.
ma'am,
Prachi,
I
how
will.
many people have already logged in?
Find out, करते ma'am. Give us a minute.
Sure.
Now we'll check. Chitra, can you guide us? How many participants are there?
Ma'am, currently 98, ma'am, currently.
Then we should start. Then
I
we should
think
Yeah, we should start. We should start.
Okay, ma'am. Thank you very much. I'm starting. So good afternoon, doctors, and a warm welcome on behalf of Shield Healthcare. Thank you very much for joining this webinar. And before we begin, we have a very short AV on Shield Connect. So I'm requesting Chitrikala to play this AV. Chitrikala, over to you. Thank you, Chitra. Thank you very much. So I'm very happy and privileged to inform you that today's webinar is arranged under the aegis of DGF North Multidisciplinary Committee and also AOGD and Breast Committee of FOGSI. So it's a collaborative webinar along with Shield. So thank you very much. And with this, may I request and invite Dr. Divya Singhal Ma'am, who is the Vice President of DGF North, for further proceedings. So Dr. Deva ma'am, over to you. Thank you.
Thank you. Very good afternoon and a warm welcome, dear friends and respected seniors. Thank you for coming on this wintry afternoon to our webinar, which is going to be very relevant. We are discussing two very relevant and significant topics, one on gestational diabetes mellitus and the other on lumps of the breast. Both the incidence of breast cancer and GDM is on the rise. And here we have today a very outstanding, inspiring gynecologist whom I'd love to welcome and feel privileged to do so. She's Dr. Sneha Bhuyar. She's Chairperson, Female Breast Committee, FOGSI, Governing Council Member, ICOG. She's recipient of National Award of FOGSI, outstanding work, metrics. Something very nice. An outstanding female doctor of the state by the government of Maharashtra. She received an award for that. And lots of many more accolades and international conferences under her under her sleeves. So over to Dr. Sneha Bhuyar. Please give us some pearls of wisdom Ma'am.
Yes, thank you so much, Dr. Divya, for that kind introduction. And at the outset, I would like to thank the Ligainik Forum, especially the North. And I can see so many of our friends, our dear members, Dr. Sushila Gupta, Dr. Shashi Kabra, and all the dignitaries and the post holders from DGF as well as AOGD. I thank you from the bottom of my heart for inviting me here. I would just like to share about the work which is done by our committee and what is our aims and objective. Our committee, as you know, it's a study on female breast disease committee, FOGSI, and maybe this committee is there for so long in FOGSI, but many of you, I'm sure, is not aware about this committee. It's since last 2 to 3 years only this committee has come into limelight. And because the reason being, we are having very active members and we are doing all sorts of work. Especially we have a 3-tier system. We are sensitizing our doctors, gynecologists regarding the domain that this, yes, breast belongs to the gynecologist. And because all the patients, rather all the women who come to us for any of their problems, and breast being such an easily accessible organ, we can anytime examine their breast and diagnose whatever abnormality is there at the earliest. We can sensitize them and we can make them aware of their breast and breast diseases, can diagnose the breast cancer at the earliest. So we have a role in preventive oncology. At second level, we are talking about breastfeeding promotion and benign breast diseases. So all three we are taking up: breastfeeding promotion, benign breast diseases, and breast cancer. And looking at the 3-tier system, that is sensitizing the doctor, making awareness and training the paramedics, especially in the self-breast examination. And of course, awareness in the common public. So that is how we are targeting all 3 levels. And over last 2 years since I have taken up, we have hundreds of activities done. Dr. Sushila and Dr. Shashi, they are with me witnessing all the activities, and they are doing fantastic activities as far as the diagnosis as well as awareness is concerned. Of course, over 2 years, we have done many mega events as well, especially breastfeeding promotion. We have done focused national conference Lactacon with Pune Obstetric Society with more than 500 delegates. And we have done a month-long breast cancer awareness project in the month of October 2019, where we have examined 2,500 ASHA workers from the entire district, and we have trained them for breast examination as well. This year we had a very huge event, you can say, e-conclave on breastfeeding during the month of August. 60,000 viewers have joined. FOGSI has witnessed that. And in the month of October, we have done a e-conclave on breast cancer where more than 20,000 viewers have joined. So commendable job by all my dear members. I'm very thankful to all of them, and our work continues. We are happy that we are able to spread our messages to all our fellow FOGSians, and that's the reason Delhi Obstetric Society, Delhi Gynec Forum, AOGD, being such a huge body, we want you to be along with us to make the awareness and make India breast cancer free. Thank you so much.
Thank you, Dr. Sneha. Thank you, Dr. Sneha.
Dr. Rhythm, kindly invite and introduce the chairpersons for the first talk.
I would now like to invite our chairperson for our talk, Dr. Pankaj Aneja. He is a very well-known endocrinologist, consultant, Max Hospital, Shalimar Bagh. Dr. Mamta Mittal, consultant obstetrics and gynecology at Fortis Hospital, President DGF North. Dr. Kiran Charba, she's a consultant gynecologist and obstetrician, Secretary DGF Northwest. Dr. Shashi Kabra, she's very well known. She's the chairperson of Multidisciplinary Committee, AOGD, Consultant Obstetrics and Gynecology. I welcome you all, and I would now request our chairperson to invite our first speaker for the day.
It's a proud privilege and pleasure to invite Sushila ji to give out a talk on GDM. She was the president of Delhi Gynae Forum North from 2016 to 18, and that is when our forum was actually built up and came up. And ever since then, she has been an advisor to DGF. Madam is chairperson of Breast and Cervical Awareness Screening and Prevention Committee. She has been chairperson of Reproductive Endocrinology Committee and Adolescent Health Committee. Dr. Sushila is the recipient of APJ Abdul Kalam Excellence Award and has been nominated as a Woman Achiever in 2019-20 by the IMA DNZ branch. And above all this, she's one of my best friends. So welcome, Dr. Sushila Gupta.
Thank you, Dr. Mamta. Such a nice introduction. And above all, which I like is you are really my friend. This is the one of the best, I think. And good evening, everybody. Today, I'm going to talk about gestational diabetes. I'm not able to change my slides.
So double click on the presentation.
Okay.
Make slideshow.
Today I am going to speak on a gestational diabetes. It is very important topic, and we will discuss why we are discussing this topic, why this is important, and how to screen and how to manage this topic. So the gestational diabetes is actually hyperglycemia, and hyperglycemia can be before the pregnancy start, and it may be appear for the first time. The diabetes in pregnancy or gestational, pre-gestational diabetes or over diabetes can be type 1 or type 2 if the fasting blood sugar level is 126 milligram per dl, or the random or PP is more than 200 milligram per dl. This is, we call it a overdiagnosis or pre-diabetic or gestational diabetes. The diabetes pre-existing from the pregnancy. And the gestational diabetes is when the blood sugar is high, but it is more than 140 postprandial, but less than 200. It's up to 199. This is pre-gestational diabetes. So the magnitude of the problem is much higher than what we see. And the prevalence of GDM is comparatively much higher in the Asian people, like 8.7%, and in the white women, 3.9%. But this variability may be because of the different criteria of the screening. So much so, when the Chennai-based hospital, when they did universal screening, they found 18.9%, and which was much lower when it was done in the higher group only. And so much so, when they did their data community-based, then they found in the urban, it was 7.8%, and semi-urban 13%, and in the rural area, it was much less, is 9.9%. And all over the states, if we are doing universal screening, the prevalence rate was much higher. So much so, when it was done in the Chennai-based research foundation with the International Diabetes Federation, they found in India alone, the GDM affects 5 million women each year. So, and pre-diabetes and diabetic affect approximately 6 million births in India alone. So this is a higher magnitude. And why we are worrying about this higher magnitude? Because we know that the maternal and fetal risk are much more if the patient is having diabetes in the pregnancy or a normal pregnancy. There's a huge long list of the maternal risk, like preeclampsia, increased cesarean delivery, subsequent development of type 2 diabetes, 30% maternal mortality rate, progression of chronic complication of the diabetes, gestational hypertension, hypoglycemia, infection, ketoacidosis, polyhydramnios, and so on and on, preterm labor. Not only maternal risk, but the list of the fetal risk is also no less. They include birth injuries, childhood obesity, hyperbilirubinemia, hypoglycemia, macrosomia, shoulder dystocia, respiratory distress syndrome, premature birth, increased cord blood serum levels. So on and on. Not only the present pregnancy complications are much more, but the fetal programming of the GDM is also like that. Those babies, they are in the pregnancy in utero, when the patient is having GDM, the chances of diabetes in later life is much, much more. Because when GDM mothers are overfed, then there is a overexpression of in the fetal beta cell. Insulin secretion is much more, and there is a exhaustion of the beta cells production. And in the later life, when more of the insulin is required, beta cells not able to produce insulin, and then they become diabetic. Not only overfed mothers, but underfed also. In the pregnancy, the programming of the beta cells, fetal beta cells are there. They produce less of insulin, and they keep on producing less of insulin even in the future if the requirement is much more. So again, they are going to develop diabetes. So we are producing more of the diabetic population in the future if we are not treating GDM at the right time. The pathophysiology will contain like insulin resistance. We know in the GDM, insulin resistance is there. And moreover, placental secretion, they also act as an anti-insulin hormone. And in the genetic and autoimmune disorders, not only this, in the later half of the pregnancy, in the last trimester, there is a glucose production from the hepatic cells to combat the fetal demand, to cover the fetal demand. So all of these criteria combined producing gestational diabetes. So why every woman doesn't develop gestational diabetes? Because there is enough reserve to combat this situation. So every normal woman doesn't develop GDM. Only potential candidate develop GDM. There is now it is sure that we have to screen, and we have to diagnose, and we have to treat this disease. And so there is a lot of variation also in the screening. Screening is also vary according to the not only the screening methods, but the guidelines are also differently saying different. But this is sure, GDM offers a unique opportunity for initiation of the strategies to not only prevent the complication in that pregnancy, but in the later life also we can prevent to develop diabetes in these conditions. And we know that approximately 2/3 will develop GDM subsequently in the later pregnancy also, and after delivery 20 to 28 years they can develop diabetes also. Coming to the screening part, if we say the NICE guidelines says only high risk women should be screened, but IADPCG, AGA, FIGO, WHO, DIPSI, ACOG, all guidelines says we should screen all women presenting to us in pregnancy. So universal screening to be done. Because if we are doing selective screening, we may miss 20% of the GDM cases if we are not doing universal screening. And more so, Indian women have 11-fold increased risk of developing GDM. And hence universal screening, especially in the Asian or especially in the Indian women, is advisable. Now, when to screen? This is also the point of the controversy. Like ACOG says we should screen at the 24 to 28 weeks, but IADPSG, DIPSI, NICE, AGA, WHO, FIGO, they all recommend at the first visit or the first trimester. If we are doing screening for the first time at the 24 to 28 weeks, then we are going to miss GDM in the early phase, and early hyperglycemic state we are going to miss. So now coming to the frequency, there is also controversy how frequently we should do. The DIPSI, what we should follow, DIPSI says we should do 3 times in a pregnancy. At the first visit, first trimester, and says the one time only 75 gram glucose, and after 2 hours we should take the blood sugar level. If it is more than 140 milligram per DL, then it should be considered and treated as a GDM. If it is normal, again we have to do at 24 to 28 weeks. If it is normal, then it's okay. If it is abnormal, then start treating as a GDM. And third time also, if it is normal in the 24 to 28 weeks, at the 32 weeks onward, again we have to do to find out whether now patient has developed, and few patients develop in the third trimester only. And again, we have to treat as a GDM. But at the same time, Ministry of Family Welfare says there is no need to do after 24 to 28 weeks, only 2 times to be done. And same with the WHO on IADPS. But NICE guideline says we should do only once in the high risk. And the history of patients are having GDM in the previous pregnancy, they should be done twice. Or ACOG also says that once in a low risk and twice in a high risk. But there are different criteria also to diagnose the GDM. The DIPSI is very simple. You have to do only one test, and single test, if it is normal, is more than 142 hours after 75 gram glucose. So you have to, this is simply, you have to diagnose GDM and you have to treat it like GDM. But IADPCA and NICE guidelines also, they are also recommending one step only with the 75 gram glucose. And but they are saying we have to take 1 or 2 or 3 readings. 92 is a fasting, 180 is the 1 hour, and 153 is a 2 hours. And with the NICE guideline, fasting 101 and 2 hours 140. And any 2 reading, any 1 reading is abnormal, you can diagnose as a GDM. But at the same time, NDD, ACGOG, they says we should do 2-step test, first with a 50 gram glucose, and second, if it is abnormal, then we have to do second step with 100 milligram, and we take all the 4 readings properly, fasting 1 hour, 2 hour, and 3 hours. And if the 2 readings are abnormal, any 2 readings are abnormal, then we can diagnose GDM. But as the same scenario, we are following DIPSI criteria, most of the Indians people. And why DIPSI is not adding fasting? Because they say in Indian women, the insulin resistance is much on higher. So most of the cases, fasting blood sugar level are normal. So there is no need to include this reading. And similarly, like COVID time, if we see, this is also very feasible during the COVID time, as patient sensitive, safety and motivated criteria during pandemic, the DIPSI criteria is very easy. Only one contact is required in these cases, and second contact for fasting can be avoided. So to conclude, Indian population is a diverse and variable, hence the international criteria on Indian population may not be conclusive. So low and middle income countries like India, we should follow DIPSI criteria, and the second visit should be avoided, and only this is cost effective also. Now we have diagnosed GDM and we have decided what method we have to use, and after that we have to start treating. On the treatment part, patient education is very, very important, because this is going to stay with a lifelong with them. And medical nutrition part is very important in the GDM. And if we are not able to control glycemic control with the medical nutrition therapy, then we have to go to the pharmacological therapy. And the goal of the glycemic control, what are the goal, and how to monitoring the fetal and planning of the delivery. I'll go like this. Patient medical nutrition therapy, we have to achieve normoglycemia, and side by side we have to prevent ketosis, and adequate weight gain should be there, and fetal well-being also be there. And nutritional plan include calorie allotment, calorie distribution, and carbohydrate intake. Like calorie intake, if the BMI is 22 to 25, then we can advise, or we can have 30 kilocalorie per current weight per day in a pregnant woman. If BMI is little higher, then we have to reduce the calorie intake, like 24 kilocalorie per kg of the current weight. And if BMI is more than 30, then definitely we have to restrict more of the calorie count, and 12 to 15 kilocalorie is advisable if the BMI is more than 35. Not only the calorie count, but the carbohydrate intake also should be limited. It should be complex type, and carbohydrate should be 33 to 40% of the total calorie amount. While in the Indian population is sometime it is more than 50%, and protein should be 20 to 30%, and fat should be 30 to 40%. And with all these modifications, almost 75 to 80% GDM cases can be achieved normoglycemic. not only the calorie count or carbohydrate cut down, sometime in Indian population we see the breakfast or meal, because insulin resistance is much in the morning times. So our breakfast, we are not able to control our breakfast, post breakfast blood sugar level. So we have to further reduce the breakfast meal, like 10% of the total calorie count can be taken in breakfast, 30% of the total calories in the lunch, and 30% in the dinner, and rest 30% can be achieved in a form of snacks in between meals. So we are able to achieve normoglycemia. And what are the goal to achieve normoglycemia? These are: fasting blood sugar should be less than 95, 1 hour postprandial should be less than 140 milligram per dl, and 2 hours should be less than 120. But these are the AOCG, but ADA says pre-meal can be 80 to 110 and 2 hour post-meal can be up to 155. Now if we are not able to achieve this glycemic control by the medical nutrition therapy, then we have to go to the pharmaceutical treatment or pharmaceutical interventions. Majority of the cases we achieve. In case if the fasting blood sugar is very high, it is more than 120, then starting, say, we can start medical nutrition therapy along with pharmaceutical treatments. In the pharmacological treatment, insulin is the first drug of choice, and there are some indications to start the insulin therapy if we are not able to achieve normoglycemic conditions by the medical nutrition therapy, and this situation is before the 20 weeks, then we have to start insulin. Or if it is after 30 weeks and we have given metformin, as a few guidelines says, the metformin is also first line of the drug. If we have given enough dose of metformin up to 2 gram maximum, then also we have to start insulin. Or if we want weight gain should be more than 12 kg, then we have to start the insulin treatment. Insulin treatment, there are two types of insulin: basal insulin, which take care of the, because this is a intermittent and long acting, is take care of the fasting blood levels, and the short acting aspart and lispro, they take care of the postprandial sugar levels. Whenever I advise insulin therapy, we advise to my patients, I always want my physician or endocrinologist should be on board, because they have much experience about the insulin drugs. We don't have so much of experience, but for the sake, the total dose varies from 0.7 to 2 unit per kg of the present weight. And if fasting levels are high, then we have to give 9 NPH, that is 0.2 unit per kg. And if we are giving bolus in the short acting for the postprandial, then it should be calculated how much amount of carbohydrate we are giving in the meal, like 1.5 unit per 10 gram of carbohydrate for the breakfast, 1 unit per 10 gram of carbohydrate in the lunch and the dinner. And if both are high, then can be 4 injections can be given. And we are having our chairperson as Dr. Pankaj Janeja as the expert, and he might tell you in the details how we going to achieve finer normoglycemic condition if the maximum like or more than 20 unit of insulin is required, because government of India says we can use premix or insulin also, that is easy to use, will come later on. But if we are giving insulin therapy, these are the targets to achieve. They are equal to the medical nutrition therapy, and apart from when we are giving insulin, there are chances of hypoglycemia, so we have to see the hypoglycemic condition also, and night blood sugar should not be less than 60. So if by the government of India, they says if you want to start insulin, you can start, but you can use premix insulin, where short and long acting is mixed 30 to 70 ratios, and you can give insulin when medical nutrition therapy is not fulfilling. And according to the sliding scale, like blood sugar, when the blood sugar levels are 120 to 160, you can start with a 4 unit, or if the 160 to 200, you can start 6 unit, or if it more than 200 unit, you can start with the 8 units, and then keep on doing the blood sugar charting every third day. And if the fasting is more after that, you can add the night dose, or if the postprandial are more, you can add in the morning dose. But they says ki you should not give insulin if the requirement is more than 20 unit. If the requirement exceeds from the more 20 unit, then definitely you have to refer to the high center, or you have to consult the endocrinologist or physician along with you. So to summarize, insulin therapy is the backbone of the pharmacological management, and the total dose, because we have to see the physician, because the total dose actually, if we want proper normoglycemic condition, then the dose short acting and long acting should be split in the 50% of the doses. So we have, jo premix hai, we are having 30 to 70% ratio. And now coming to the oral hypoglycemic agents, John Hopkins University says maternal glucose levels did not differ substantially between gravids if we are giving oral hypoglycemic agents like metformin or glyburide. They are also equally safe, but at the same time, we are not having prolonged data for this. Second generation sulfonylurea are also safe, and the placental transmission is very less with them. Only 1 to 2% of the maternal concentration is seen in the fetal circulation. But metformin crosses placenta, but at the same time there are no teratogenic effect in the rat models with the metformin. So metformin is also very important drug to control GDM, but maternal side effects like GIT disturbance, nausea, vomiting, loose stools are also there. But at the same time, metformin is not metabolized and is excreted unchanged by the kidney. And the dosage, we can start with a night dose only 500 milligram, so that body can adopt, and then later on we can increase after 1 week 500 in the daytime, morning, and up to 2 gram in a divided doses. And this is the comparative chart of the insulin and glyburide and metformin. Metformin, the benefit is easy to give, easy to give, and there are no chances of hypoglycemia. But the GIT disturbance are there, and in the insulin and glyburide, the chances of hypoglycemia are there. But at the same time, insulin is very comparatively also very safe drug, is considered first line drug, and easy to give these days because we have so much easy to monitor the insulin dose. And the recommendation from the professional bodies, ACOG says the insulin is first line and second line is metformin, but Society of Fetal Medicine says the insulin and metformin both can be used as a first line drug, and second line can be glyburide. So there is one published from the Society of Fetal Medicine in March 2018. They say if we are not able to achieve normoglycemia with a medical nutrition therapy, then metformin reasonably can be used as a first line of the drug, and it is quite safe. But at the same time, long-term data is not there. So whenever we are prescribing hypoglycemic agents, we have to repeat thorough counseling of the patient to be done. Again, we have to explain to them that this is a category B drug and the first line is insulin. And if it is very difficult to take insulin, we can prescribe you metformin, and it is quite safe. So there are recommendations from the ADA Society in the 2019. What they say is lifestyle change is essential component and may suffice for the treatment, but the insulin is preferred medication treating hyperglycemia in the gestational diabetes, and metformin and glyburide should not be used as a first line agent. This is a category evidence. And metformin, when used as a PCO in a patient of PCO to induce induction of ovulation, then it should be stopped when pregnancy is confirmed. So now this is coming to the current treatment paradigm. We are having very experienced in using ionositol in PCOS patients, and very effectively we are using them and insulin resistant cases. So it should work in the GDM also, and it is working in the GDM also. But at the same time, it is safe and it is easy to use and acceptable for the patient. But the problem is there is a limited experience. There are no guidelines about the use of inositols, and the confusion of the dose, which dose should be given at what sugar level. But at the same time, we know the inositol, minoxidil, and dechironositol are the important member of the inositol families, and they have a major role in the carbohydrate metabolism. And we know that in the pregnancy, if pregnancy state is seen, the minoxidil and dechironositol is quite low in the GDM patient as compared to the normal pregnant patients. But at the same time, if we are supplementing MI and DCI in 40:1 ratio, then insulin resistance is diminishing and insulin becomes normal, and blood sugar also becomes normal. So it appeared that minoxidil shows promise in reducing the risk of gestational diabetes, but at the same time, all the evidence is based only on 4 small trials, 3 published trials, and 1 conference abstract. And now coming to the monitoring should start with the preconceptional period. If pre-gestational diabetes is there, then we have to look for the nephropathy, retinopathy, and the prior to the pregnancy, and glycemic control should be controlled before starting the pregnancy. And in the pregnancy, glycemic control with the medical nutrition therapy, exercise, and pharmacotherapy. Near perfect glycemic control is the key to prevention of all the complications. And ultrasound should start in the normal cases also for the dating scan, then cardiac activity scan, and anti-NB scan, and level 2 ultrasound in the diabetic patient should be done with a fetal echo. And biometry should start after 28 weeks. And the frequency of biometry depends upon the how much your glycemic control is there and associated problems like PIH and all, 2 weekly or 3 weekly, depending upon the glycemic control. And delivery, induction of the labor, there are FOGSI ICOG 2018 guidelines. Induction of labor is not recommended before 39 weeks with the gestational diabetes, or if gestational diabetes is controlled on diet, we can deliver them at the 39 weeks, but not before the 39 weeks. But at the same time, if we are giving insulin or oral hypoglycemic agent, we can start induction, or we can deliver them at 38 weeks of gestation. And if the diabetes is uncontrolled or other associated problems are there like PIH and all, then we have to individualize the patient. We have to deliver sometime at 37 weeks, or we have to customize their patients how much glycemic control is there. So to conclude my talk, this is GDM is an epidemic, and we have to curb this epidemic. And most important point is we have to educate our medical fraternity, because most of the medical fraternity, they are not aware of GDM and the treatment of GDM. And if we are treating GDM, we are preventing further generation to develop diabetes. And then comes a patient education, universal first trimester screening, especially in Indian condition, and use a single method and routine screening that is cheap also and effective also. And then we should take the preventive step and early management, so that we can prevent our next generation to become diabetic. Thank you so much.
Thank you, Dr. Sushila Gupta. That was a very comprehensive talk on GDM. And I like the way you said that GDM has become an epidemic. We all need to note that. Dr. Aneja, Dr. Pankaj Aneja, we'd like your expert comments on this. Dr. Pankaj Aneja.
Thank you, Dr. Sushila. It was a very lucid presentation on GDM. And I think you covered everything so well and added to my knowledge also. I'm grateful. I would like to add a few fine points. No doubt the mainstay of treatment for management of diabetes remains insulin only. And if we are initiating insulin, we have to be very careful. Number one, as you very rightly said, basal insulin has to be given at night. Basal insulin starts action and it remains there for 24 hours. So basal insulin at night will give a good coverage for controlling blood sugar, for fasting, as well as for throughout the day. Then we need to take care of upsurge of glycemia, which happens with each meal. 50% of dose of the insulin goes as a basal shot, and rest 50% has to be divided into 3 dosages, and it has to be given in the form of boluses. For this, we have time-bold insulin as well as we have analogs. Analogs are better than human insulin, which was there earlier. Why? Because the response is more predictable, number one. Number two, by using analog, the chances of hypoglycemia are less. So analog 3 times before breakfast, before lunch, and before dinner. At times, you find that patient does not require analog insulin, short-acting insulin before breakfast, because hardly 10% of calories are being given at breakfast. And we need to give insulin before lunch and before dinner. So that becomes a basal plus regimen. When 1 shot of basal is being given and 1 shot of regular insulin is being given, it becomes basal plus. At times, you have to make it basal bolus, where 3 shots of regular insulin is given to take care of hyperglycemia, which is happening with each meal. Nowadays, we have ultra short acting insulin with the name of FOGSI. That is a very good insulin which we use in pregnancy. Why is this? Because that insulin can be injected even after meals. At times when I am treating a GDM patient, the lady complains, I myself do not know when I'm taking insulin whether I'd be able to eat or not because of my nausea and vomiting. FOGSI is an ultra short acting insulin and can be given even after meals. So even 5 to 10 minutes after meal, it acts very fast. Action starts within 5 to 10 minutes, reaches its peak within 30 to 45 minutes, and the action lasts for overall maximum of 4 hours. So 3 shots of FOGSI insulin can be given to take care of post-parental hyperglycemia, along with 1 shot of basal insulin. You need to up-titrate basal insulin depending on the fasting blood sugar level. And you need to up-titrate or down-titrate boluses depending on the 2 hours post-meal blood sugar level, which are being seen after breakfast, lunch, and dinner. As far as the use of premixed insulin, as you were discussing about 30-70 insulin, the biaspart insulin, here the 30% component is the short-acting and 70% is long-acting. But mind it, this insulin needs to be given twice a day, before breakfast and before dinner, with a gap of 11 to 12 hours between the 2 dosages. The only problem which remains with biaspart is you have already shot from your gun. You have already given the insulin. At times, the patient is not able to have lunch properly, and patient is having nausea, vomiting, and the chances of hypoglycemia increase. Secondly, whenever you are prescribing a biased insulin, you must tell patient to shake the pen vigorously 5 times, because it becomes a uniform suspension. Many a times I have seen patients saying that today I took, say, 12 units of biaspart premixed insulin, and today I got a very good response. Next day I did not get the same response, despite the fact that my meal pattern did not change. Why does it happen? It happens because the patient did not shake the pen, and only the shorter acting component went into the patient and produced hypoglycemia. At times, only the longer acting component went into the patient, and the patient got a hyperglycemia. So whenever biaspart is being used, which I usually do not prefer in pregnancy, because I have seen pregnant females very enthusiastic as far as checking of blood sugar is concerned. I find them very receptive, or even taking 4 shots of insulin a day. So my choice, personal choice, remains using a basal bolus regimen, and that too checking blood sugar very frequently. I tell my patients to check blood sugar not less than 4 times a day, 1 fasting and every time 2 hours post meal, and SOS if there are any symptoms of hypoglycemia.
Thank you, Dr. Pankaj Juneja.
Dr. Pankaj, just one question. What is your opinion about oral hypoglycemic agents? You know, I'm very, very scared of hypoglycemia in pregnancy. It causes fetal distress. It causes sudden fetal demise.
Madam, oral hypoglycemic agent, legally, we are not very safe in using them. Of course, metformin we can use, but I do not use any sulfonylurea. In fact, sulfonylurea like glyburide, they are more notorious to produce hypoglycemia. Insulin does not produce hypoglycemia. It's a short acting. It hardly acts for 4 hours. And you have something in your hand after 4 hours. Once you give an oral hypoglycemic agent like glyburide, sulfonylurea, then for 24 hours, the chances of hypoglycemia are very high. Moreover, you do not know how is going to be the oral consumption of the patient. So it is always better to give insulin. And I have seen pregnant female, honestly, you know much better than me. They always agree to insulin. And insulin is very safe. Something in your hand once you have injected. Because after 4 hours, the effect is going to vanish. And basal insulin does not produce hypoglycemia significantly. Nocturnal hypoglycemia, oral hypoglycemia is very less with detimer insulin, the basal insulin, which has been approved to be used in pregnancy.
Metformin, sir, doesn't give, I mean, it's only for gestational diabetes, okay, you know, managed by diet. Those milder forms are responsive to metformin. You cannot give a very high dose of metformin.
I 100%
Also
agree.
in later trimester, third trimester, later on even metformin, sometimes blood sugar becomes uncontrollable with metformin. Then we have to change over to insulin.
Very right.
So I personally prefer only giving insulin. And whenever a patient is referred to me with getting metformin, I usually change over it to insulin in 2-3 days time.
But
This is
now
what
I 100% go with
it's
you.
happening that more and more people have started taking metformin because they don't like to take insulin.
Yes.
So Dr. Pankaj has a different opinion about it. But as far as I am concerned, I feel whenever you ask the patient that you take insulin, patient is so much afraid of taking insulin, because she thinks if once I start taking insulin, I will be taking insulin throughout the life. So she will go and change a doctor, and then she will go and get that metformin again. She will start on metformin. So what we are giving I will say, to our society, or what we are telling us gynecologists friends,
According to Society of Fetal Medicine, if the requirement of hypoglycemic agent, insulin or oral, whatever we require, if this requirement comes after 20 weeks, we can start metformin. But at the same time, 2/3 of the patients, they are going to require insulin anyway after that. They are not going to settle with metformin only. So you can start metformin if the requirement is required after 20 weeks. This is the Society of Fetal Medicine, is a recent 2018.
Yes.
But at the same time, they say whenever you are starting oral hypoglycemic agent, you have to re-counsel them about the safety issues, because we are not having long-term data. If there is something happening to their child, because up to 5, 6, 7 years data are there, but long-term data are not there, what is the consequences of the metformin? Although it is considered comparatively safe than sulfonylurea, glyburide, like Dr. Pankaj Janeja says, because the chances of hypoglycemia is not there with the metformin. But at the same time, we can start, but very mild patients are going to settle with metformin only. Or 11% of the patient whom we are starting metformin, they can drop at any time because of the GIT disturbances. Almost follow-up patients usually do not want to take metformin also. Almost 11% dropout rate is there because of the GIT symptoms.
Yeah, we are always safe with insulin.
That way, insulin is the safest drug. Yeah. And now it is very easy to calculate also. And now we have to counsel them. This is the safest and easy. Even now they are promoting insulin at the PSC level also, because they are saying you can keep insulin vial or insulin syringe in the earthen pot also. There is no need to keep in the fridge also. So they are promoting, because this is the safest drug, comparatively is considered safest category 1 drug. And the chances of hypoglycemia, like Dr. Pankaj Janeja says, very, very less comparatively if we are monitoring properly.
I would just like to add one more point, ma'am. The secret of success to start with the insulin will depend on the amount of time, amount of counseling done by the treating doctor. If you counsel them well, and we have in our in-house diabetic educator and nutritionist, which are there in our clinic. So they spend 10-20 minutes. Maybe the patient has so much of apprehension and caution in their mind And we are not ready to answer all those questions because of paucity of time. The diabetic educator, the insulin educator and dietitian spends half an hour with a patient of GDM, and he or she allays all the apprehension and fear in the mind of the patient. Second fear, which is always there in the mind of the patient, is what is going to happen if I have got hypoglycemia? What is going to happen if my sugar is on the higher side? So you have to give that confidence to the patient. I honestly give my mobile number to all my GDM patients. I'll tell them I am available 24/7 for them. Take my number. I would not mind if you are even WhatsApping me your diabetic chart every day. I can counsel you every day, whatever plus and minus sugar is to be given. If you infuse confidence in the mind of the patient that he or she will not get hypoglycemia, aware them what are the signs and symptoms of hypoglycemia, I don't think any reason why insulin cannot be prescribed. It is the safest, it is the easiest, and it is the best for to manage GDM patients.
Thank you, Dr. Pankaj, for convincing us about insulin. Of course, tablet metformin is another alternative. What I wanted to ask from you was that having given insulin and we do a 2-hour postprandial level of glucose, and we find that it is more than 120, it's between 120 and 155. So is that acceptable or not?
No. It is acceptable as long as it is closer to 120 or 125. If it is 2 hours postprandial sugar is going more than 125, I need to up titrate my shot of bolus insulin by maybe 2 units. Or maybe I need to reduce the glycemic index of the food. Maybe I need to take care of the carbohydrate content of that meal, and I need to reduce the carbohydrate content. But up titrating by 2 units of insulin would be sufficient to take care of blood sugar, say around 130, 135. That will take care.
Thank you. So we'll take more questions later on. And now I request Dr. Kiran Chabra to introduce our next speaker.
So friends, after listening to such an elaborative and topic given by Dr. Sushila and a good discussion on what to use with our GDM patients, we move on to another topic which is also very significant in our field, that is how to approach a breast lump. And the speaker for that is Dr. Vedant Kabra. He is head of the department Surgical Oncology, Manipal Hospital, Dwarka. He is trained oncology surgeon from Tata Memorial Hospital. He has many fellowships from overseas, Singapore, Belgium, and Sunnyvale, USA. He has many awards to his credit. He's a gold medalist in Final MBBS. He has a Best Resident Award and Best Research Paper at ESICON. He has very good record of his academic activities. And one more important point to his favor is that he is Dr. Shashi Kabra's brother. So we welcome you, Dr. Vedant Kabra, and we are waiting so that you can enlighten us on this topic. And as Dr. Sneha has said that gynecologists should take all this in their hands now. They should start helping the society in preventing the breast cancer. So over to you, Dr. Vedant.
Thank you, Dr. Chabra, for a very kind introduction. I hope I'm audible.
Yes, you are.
So I'll share my screen and then we'll start. So as you mentioned, Dr. Buyar has mentioned a very important point. Most of our patients actually come to us after going to a gynecologist, and it is very important that we partner in their care and provide them adequate care. There should not be inappropriate delays. So, and breast cancer management, obviously, usually in India is done by a surgical oncologist or a breast oncologist, but we need to partner with gynecologists so that even a post-op follow-up care or post-treatment follow-up care can happen there. So before I start, I would like to thank Delhi Gynae Forum North and especially Dr. Sushila Madam, who invited me for this talk through Dr. Kabra. And I'll now start this. So basically, this is how the flow of talk is going to be, starting with clinical evaluation, which seems very basic, but many a times we miss things. Then going on to imaging, pathology, which are very important legs of evaluation. And then joining all these dots, all 3 dots.
So we cannot see your slides.
Oh, I have already shared the screen and okay, no problem. I'll just do it again. Huh? Just a minute.
Dr. Sushila, ma'am, you'll have to stop sharing your screen.
No, she has stopped. She has stopped. I'll just share it in a minute, please. Is it visible now?
Yes, sir, it's visible now.
So the flow of talk I was mentioning would be clinical evaluation, imaging, pathology, and then joining the dots of what all these three things have provided to us to achieve at a proper diagnosis, and then certain do's and don'ts, and finally maybe a couple of examples of patients on how we approach breast lumps. So the goals of a breast lump approach should be, the first goal, obviously the lady comes to you or to us worried about only one thing, which is malignancy. So we have to either exclude or confirm malignancy if there is a suspicion. Not only that, even if we have excluded malignancy, we need to provide a diagnosis, because we have to close the matter. We just can't say, oh, this is not cancer in you, go away, because many of them are worried. Many of them may not be even having lump. They might be just having a mastalgia. And there comes the importance of counseling. Just like in GDM, counseling is very important even in breast diseases which are benign and really don't need any treatment. And then finally, as I said, we provide an explanation for the diagnosis and the treatment or the approach we are taking for following up that lady. Please remember, we must prove all the lumps to be benign before deciding to observe them. And that is very, very important, extremely important. Many a times we have seen lumps which were thought to be benign actually turned out to be malignant, but were diagnosed to be malignant few months later when malignancy had advanced to a much later stage and sometimes even incurable stage. So coming to history, again, very simple things, but these are the red flags in history. If there is a growing size, especially if it is painless, most of the breast cancer lumps would be painless. Only around 15-20% patients would report some kind of pain. They may themselves say it feels very hard, is irregular. There are some skin or nipple changes that they may report. And if there is a nipple discharge, especially if it is serous, single duct, unilateral discharge, or if it is a bloody single duct discharge, please be sure of the color of the discharge. Many a times patient may say it is bloody discharge, but when we see them on a white piece of tissue, you find that it is actually a muddy colored greenish discharge of ductectasia rather than a bloody discharge. So that must be ensured. Again, detailed history, obstetric and menstrual history, you all would take even better than us. But beyond that, what is important is a family history, and it should be an extended history, extended in terms of family as well as in terms of disease. Extended family means we have to go back 3 generations. So the lady herself, her parents, both sides, and grandparents, both sides, and their cousins. So it's a very extended family. It takes maybe a minute more to ask that. Many a times on first go, they will say, no, there is no history. But we have to poke a little further. We have to give them second chance that you can inquire in your family and come back to us. So this is extended family. Now, extended diseases, it is not only breast cancer. There are a whole lot of cancers which are related. Most common, as you all know, is ovarian cancer, but endometrial cancer, colonic cancer, prostatic cancer, pancreatic cancer, sarcoma. So these are all related in some rare syndromes with breast cancer. So a very detailed family history is required. Any history of breast biopsy or any breast disease, because some of the breast diseases do lead to increased risk of breast cancer subsequently in life. And obviously, like any other disease, a systemic assessment is needed. While doing a physical examination, the exposure has to be proper. Most of the gynecologists being ladies, it is not a problem, but many a times patients would, when they come to us, or a male gynecologist is seeing, they may hesitate for exposure, but that is something to be ensured that they expose properly, have a chaperone, and it has to be waist up. They must be examined in supine as well as sitting position, and systematically all areas of breast have to be examined very slowly. It takes a little bit of time. You can't just examine in 5-10 seconds the whole breast. And it is always a good idea to document your examination findings using the figures, and it will help you in follow-up of the patient as well. Now, physical signs, what could be the red flags? Like there is any asymmetry in shape and size of the breast on both sides. And usually you will find one of the breast maybe slightly larger, but that's okay. A big discrepancy in shape and size or asymmetry of the nipple on both sides nipple inversion, retraction, and destruction. These are three very different things, and I'll show them by pictures. So this lady has a definite asymmetry in size and shape, as well as the nipple level. You can see that the right breast looks to be affected by something. It is pulled up, and there is slight inversion of nipple, very, very minor retraction, not inversion, retraction of the nipple. If you see this, there is again a nipple retraction, which is quite evident, and there is a partial destruction of nipple, which is a very strong sign of Paget's disease most of the time. There is a nipple deviation as well as retraction. And this is nipple inversion. So there is a difference. This retraction is it goes back, and inversion is it interns, it goes inside. Both are very strong signs of malignancy if this is a recent occurrence. But please remember, there are certain chronic diseases like chronic granulomatous mastitis or tubercular mastitis, which may show you clinical features which are absolutely mimicking the cancer, and imaging also many times may not help. Coming to skin retraction, there could be retraction of skin, tethering of skin, edema, or what we call as peau de orin, inflammation, ulceration, and satellite nodules. And most of them would be there when the cancer has advanced to a fairly advanced stage. This lady, apparently, you would say there is no asymmetry on both sides, but when we ask her to raise her hands, you can see there is a clear-cut asymmetry, and there is a skin dimpling on the left side, or skin retraction on the left side. Again, you can see this figure I am showing again because this part is showing skin tethering, where it is almost tethered to the underlying lump. The one which is lateral is not tethered to the lump, but there is a dimpling of the skin. So there is a slight difference between the two, and there is early nipple retraction. And these are fairly advanced cancers. There is no doubt about the diagnosis, but we need to definitely do a biopsy so that we know what type of cancer it is. And finally, the character of the lump. It is hard, irregular, less mobile. Fibroadenoma would be a very freely mobile, very smooth kind of lump. Sometimes fibroadenomas, or many a times, in fact, they could be nodular, but they are very freely mobile. And presence of lymphadenopathy, again, is a red flag, especially if it is a largish hard nodule, it's a rounded one, or it is a matted nodule and fixed to each other. And this is how I would document for all my patients. I may not use multiple colors, but I definitely try to use the diagram, and these two dimensions I would like to mention on the figure. This is for the lymph node on the axilla, and these shaded lines I use for denoting the dense area of the breast. You can devise your own method, but it's always a good idea to document it this way. So just to have a broad idea of an algorithm, if there is a breast lump on presentation, the patient says there is a breast lump, you will examine her. You don't find any abnormality. In a very young lady, you can reassure the patient. But in an older lady, 40 and above, definitely ask for a mammogram. If you have any suspicion, at least ask for an ultrasound in a younger lady. If there is a thickening of some area, which again in young ladies you will find denser areas, especially in upper outer quadrant, very, very frequently. Some of them will have dense areas in whole of the breast, which is a normal thing. Many times we have seen the patients would come and say there is a lump, but they are examining in wrong way. They are not examining the flat of their fingers. They are either poking inside or they are pinching the breast. And once they start pinching the breast, they will feel lumps which are actually not lumps. They're just nodularities. They might be doing examination at the wrong time of the cycle. The right time is around a week after the first day of the period. So if it is not very concerning, we can reevaluate at a short interval with maybe 2 to 3 months. But if you're worried, we must go for imaging. There is a clinically benign thing. Also, if there is a finding, we have to do certain kind of imaging, age appropriate imaging. If it is clinically suspicious, again imaging, and not only imaging, but also a biopsy has to be done to confirm the diagnosis. Now, in the imaging, if there is a clinical abnormality present, then we ask for mammogram beyond 30 years of age. It should always be done even if malignancy is proven. Sometimes patients would say, cancer to pata lag gaya, doctor, why are you asking for a mammogram? So that's not the right thing to do, because mammogram may find additional cancers in the same breast or even in the opposite side. It should always be bilateral. Whenever we are asking for a mammogram, please always ask for bilateral mammogram. At least Two views are done, which is mediolateral, when the breast is compressed like this, and a craniocaudal when the breast is compressed supero-inferiorly. And sometimes additional views are needed because they want to magnify, they want to have a extra view which might have missed certain part of breast. Mammography will never be able to catch whole of the breast, and especially in ladies with larger breasts, there are some areas which remain blind to mammogram always. Dedicated and experienced radiologist is needed, and very important, please always insist that they should report based on BIRADS and ACR grading. This is American College of Radiology, and these are two different things. ACR grading is done for the density of the breast, whether it is A, B, C, or D. A is a fatty breast and D is an absolutely dense breast. And BIRADS grading is basically the suspicion level of the abnormality that they have found. A hand lens is nice if they come with the films. We can have hand lens to examine certain things. Otherwise, packs, the hospital packs will give you the chance to magnify the films and see it. Now, mammography should be done, as I said, for all palpable masses or suspicious thickening in a lady who is over 30 years of age. It should be done if there are skin changes and there are inflammatory breast findings which are suspicious and which are not responding to proper anti-inflammatory and antibiotics. There is axillary lymphadenopathy, which is suspicious, but a normal clinical breast examination, because we can sometimes find a very small lesion in the breast, which is not palpable, but has gone to the lymph nodes in cases of certain varieties of cancer, which are more aggressive. Any newly diagnosed breast cancer, I've already mentioned that. Symptomatic males, so males would not obviously come to you, but if all male patients also they have lumps, they should undergo mammogram, which are if there are clinical suspicion for that lump. And definitely screening mammogram, which is very lacking in our country. And I must tell you that please use the opportunity of a contact with any patient or their relative to convince them for a proper screening, and not only screening but also for breast self-examination. In our country, where we find 60% plus patients in stage 3 and 4, even a self-examination and an awareness would do wonders to decrease this figure from 60 to 40 and ultimately maybe even less. There was a time when 80% of the cancer used to come at 3 and 4 stages. So self-examination and opportunistic screening is what I call for India, because there is no proper screening program run by our government. And so it's an opportunistic screening when patients come to you. On mammogram, if there is an irregular or a nodular lesion seen, there is a speculated margin, indistinct or micronodular margins, calcifications which are micro calcifications, very tiny calcifications, but tiny calcifications could also be benign. They should be a clustered kind of microcalcification or pleomorphic. By pleomorphic, I mean different areas of calcifications are different. So different points of calcifications are different from each other. It could be a linear or a fine linear branching. Why linear and branching? Because the calcification actually happens along the ducts. The disease happens either in the ducts or in the lobules. Most of the time when we see calcification or microcalcification, it is because of ductal carcinoma in situ, and it happens in the ducts. So a linear or a branching linear, which is signifying the branching of the duct. Many a times it would need magnification views and hand lenses to see. And these are certain mammograms. That the top picture is showing a very speculated margin and a lot of microcalcification, mostly within the lesion, a bit outside the lesion. The one on your bottom left of the screen is a irregular, finely nodular margin, again very suspicious. And one on the right lower margin, you can see there is a lesion in the retroareolar area on the right breast. So the image seen on the left of this picture is right breast, and there is an extensive microcalcification which is going much beyond the lump. And there are implications, because in this lady, however small the lump may be, we cannot preserve the breast. Half of the breast is involved, more than half of the breast is actually involved by microcalcification, and we should do a mastectomy for this lady. Then architectural distortion, skin thickening, all these things can be very well seen on mammogram. And this picture, if you compare the two sides, the picture on your right of the screen is actually the left breast, is showing very thick skin and denoted by arrow. You can compare both sides. This is a very strong sign of underlying malignancy. Sometimes we see it in granulomatous mastitis as well. Now, I was talking about BIRADS. BIRAD 0 means it needs further assessment and mammogram alone is not adequate. When can it happen? If you see this lady, there is a lot of density in breast. This one also can sometimes be labeled as BIRADS 0, but a lady with lot of density all around will definitely be labeled as BIRAD 0. This one having skin thickening, they will put, there is a strong suspicion, but they might ask for additional imaging. BIRADS 1 is a normal mammogram. You don't find any lesion, any calcification, benign or otherwise. BIRADS 2 is a definite benign finding where you really don't need to do anything immediately and lady can just undergo a regular mammogram. BIRADS 3 is most likely benign, but we need to have a short follow-up. And typically this follow-up could range anywhere between 3 to 6 months. We need to repeat the imaging to confirm that this remains stable and then we go back to normal imaging. BIRADS 4 is suspicious and BIRADS 5 is strongly suspicious. And here is the case of doing a biopsy always. BIRADS 3, sometimes we do a biopsy, but BIRADS 4 and 5, always a biopsy must be done. And BIRADS 6 is for a proven malignancy. As I mentioned, sometimes they would already have FNAC or biopsy done, and then they come for mammogram. Again, ultrasound is a very important, not only important, but also a very accurate tool. It can characterize the masses, so whether it is solid or cystic. We can never know whether it is a cystic mass on mammogram. It will look as solid only. It will look as a density, but ultrasound will characterize and differentiate between the two. It can detect multicentricity, especially in a dense breast where mammogram will not show smaller lesions. It will also be good, much better than mammogram to comment on the character of the lymph nodes. So on mammogram, many a times we see lymph nodes. Some of the radiologists may report also lymphadenopathy, suspicious lymph nodes, but that's not the right thing to do. Mammogram will not characterize the lymph nodes. Ultrasound are better for characterizing the lymph nodes. You can see cortical thickness, you can see lot of loss of fatty hilum and many other things. And imaging ultrasound is also used for guided procedures like guided biopsy, guided FNAC, clip placements during biopsy. Sometimes we also place a clip into the tumor because those tumors which are very large sometimes may require chemotherapy to downsize them and then subject them to surgery. And in such patients, there are instances when chemotherapy has completely, the tumor has completely responded clinically as well as radiologically, and then we would not know which area to remove. Patients may say, why do you need to remove? But we need to remove because almost 40% of these patients who have shown radiological complete response will also have residual disease. So guided procedures like clip placement and biopsy, again, ultrasound becomes very, very important. However, we must ensure that our sonologist is a meticulous person, is skillful for breast ultrasound, has experience of breast ultrasound. They can perform needle biopsies and localizations. BIRADS reporting, not only for mammogram, but any breast imaging, BIRADS reporting is necessary. And if mammogram and ultrasound both are being done, we have to have a common BIRADS reporting combining the two reports and not separate BIRADS for ultrasound and ultrasound and mammogram. Please remember again, both breasts and axilla have to be imaged. So there are indications for ultrasound. As I said, it can characterize a mass into solid, cystic, or a solid cystic combined. It can distinguish from lumpiness, which is there. We often feel there is a lumpiness, the patient may also feel, which actually is normal breast tissue. Then MRI detected mammo-occult lesions. So a lady who comes with a lymphadenopathy, we do a mammogram, we don't find anything. We do MRI and find a mass even in the breast, and that is what most of the time happens. Axillary node, which is suspicious, which is proven to be having cancer, with a normal breast examination and mammogram, if you do MRI, you will pick up few lesions. Now, such patients can be subjected to ultrasound again, because on a second look ultrasound, having the knowledge in retrospect that MRI has shown a disease or some lesions in particular location of the breast, most often the radiologist would find that on ultrasound. So you can use ultrasound to biopsy that lesion. Otherwise, MR guided biopsy will be needed, which is available at very, very few places. So these are certain benign lesions. On the left is a completely black, uniform, thin walled. It's a cyst. There is no doubt about that. On the right, it's again a smooth kind of oblong lesion most likely a fibroadenoma. Now this is having an irregular margin. There is acoustic shadowing at the back. This is taller than wider. So this is again a very strong suspicion for cancer. This one again showing micronodularity, quite an irregular kind of surface. And this one is also suspicious, needs a biopsy definitely. MRI is usually a problem solving. It's not the first investigation of choice. Only when the mammogram is not able to show us nicely, or ultrasound and physical examination findings and mammogram findings, they're not matching with each other, or in cases where mammogram is a dense mammogram, where the breast is very dense and we need to be sure that there are no other lesions in the same breast before we proceed with breast conservation surgery. In such cases, MRI comes very handy. If we use MRI in all the patients, it is clearly shown that the rate of mastectomy will go up, because MRI will show some abnormality which ultimately does not turn out to be cancer. So in a fatty breast, if there is a solitary lesion seen on mammogram, we don't need MRI, only for dense breast. And as I mentioned earlier also, axillary node malignancy with unknown primary site, occult primary in breast can be found out. And finally, multicentric disease, again in dense breast. Sometimes staging, because MRI again is a very good imaging for telling us the character of the nodes. And high risk screening. By and large, screening is by mammogram and supplemented by ultrasound if needed. But for high risk women, for example, a family with BRCA positive and any other person who is BRCA positive in the family has to have annual mammogram as well as annual MRI. So MRI forms a part of screening only for very high risk individuals. This is just an example of MRI. If you see, there are definitely 3 lesions seen in this MRI, and this lady on mammogram was showing only the bigger one. Just one lesion was shown on mammogram. And good that we did it, because a young lady wanted a breast conservation, but with this kind of disease, we could not offer her breast conservation. Now coming to pathology, which is very important. FNAC at one time used to be the run-of-the-mill solution for all breast lumps. Not anymore. We never ask for FNAC as the first investigation, because FNAC has a it does not have a very good sensitivity, around 70% sensitivity. Specificity may be very high, but there are other reasons which I'll come to in subsequent slides why we don't do FNACs anymore. So core biopsy, or we call it a true cut biopsy or a gun biopsy, is the procedure of choice. There are other procedures also available, like vacuum assisted biopsy, mostly done in cases of impalpable microcalcifications only, or we can do it for a image wise. If it is a clearly benign thing and the lady wants it out, you can avoid surgery and ask for a vacuum assisted biopsy, where they can almost 99% of the lesion can be removed. Incisional biopsy and excisional biopsies are not practiced anymore most of the time. Very rarely, when we are not getting a diagnosis on a core biopsy or a true cut biopsy, we have repeated it and still we are not getting it, then we can resort to one of these, but with a frozen section control and with a preparation that if it turns out to be malignant on frozen section, we are ready to complete the surgery in one go. Otherwise, if we do excision biopsy and we find cancer later on, she will require another surgery. So frozen section must be added, and we must also plan our incisions very nicely so that we take care of future histopathology coming as malignant. Now, FNAC is very easily performed, is readily available also, and it has less pain, ecchymosis or hematoma. But the problem is it has insufficient material and low accuracy. As I said, 70% sensitivity, which is not a very great sensitivity. And this sensitivity also is in the hands of an experienced cytopathologist. Not always. Most of the time we find atypical cells, the material is not adequate. More important than that is that FNAC material, no pathologist can comment on invasive character of the lesion. We have seen many a times FNAC is reported as invasive ductal carcinoma. I don't agree with that diagnosis, because invasion is invasion of basement membrane. You cannot comment on it based on FNAC only. It has to be tissue which is showing basement membrane and invasion of basement membrane. And the other important reason is we cannot subtype the disease. I'm sure most of you know that we do estrogen, progesterone receptors, HER2 receptors, and these things are not sometimes possible on FNAC, or they are not so reliable as they are reliable on biopsy. So if we have to do FNAC, who will do it? It can either be a pathologist or a clinician. There is always a dilemma, but somebody who knows how to do it properly can do it. However, I would again say, please prefer a true cut biopsy. Only if the lump is very well palpable and is a uniform lump on imaging, we can do a non-guided biopsy. Otherwise, most of the time, if it is a very small lump, not very well palpable, or it's a heterogeneous kind of lump with necrosis or a cystic component, it is better to ask our radiology colleagues to do it ultrasound guided. So core biopsy has a better accuracy. It gives us much more tissue. So the drawbacks of FNAC are all taken care of, and this is the current standard of care. It does cause a little bit of discomfort, is always done under local anesthesia, is an OPD procedure of 10-15 minutes, and the cost is also much higher as compared to FNAC. But then we are getting much more information also, and we don't need to repeat the core biopsy almost 90-95% of the times. As I said, this is a local anesthesia procedure, very small cut, 2 to 3 mm. We don't even need to stitch it. It will not bleed if we put adequate pressure. Even the ecchymosis can be taken care of. So the procedure has to be followed, and then it becomes a very, very smooth and well tolerated procedure without pain. This is how we do it. There is a strong, long spring loaded gun. This white thing is a gun and the long needle is there. And if you see the lower figure, you can see at the end of this needle, there is a long tissue block. This is a 2 centimeter long and a couple of millimeters broad, which is very good for any kind of molecular studies or immunohistochemistry markers. Now coming to joining these dots, this is the triple test. Any palpable lump has to undergo triple test: clinical examination, radiology, and pathology, and in the same sequence. We must examine them, then decide upon which modality of radiology, and finally pathology. So if a mammogram has been done, but we need an ultrasound or MRI, please do that before we ask for pathology. If we do biopsy first, then the interpretation of MRI as well as ultrasound will be modified, and it becomes difficult for our radiology colleagues to give us the right kind of diagnosis. So for all solid masses, clinical, radiology, and pathology, there is a role of multiple disciplines here, and we have to act as a team. We have to keep communicating, which is more important. If we have sent for a mammogram, many times I have found a lump in upper inner quadrant, and the radiologist is reporting in upper outer quadrant. So we have to be sure that what we were looking for, radiologist has seen it. There might be another abnormality in upper outer quadrant, but the radiologist might have missed the other one which you found it. So there has to be a coordination, and we have to see that they are concordant with each other. Very, very often we find there is discordance, and if we discuss with our pathologist and radiologist, we would know that this patient would need a repeat biopsy or an excision biopsy. We cannot just let them go like that. A biopsy may not have hit the right area. So if radiologist is saying it is BI-RADS 4, especially if it is BI-RADS 4C, so 4 is A, B, and C, and 4C is very suspicious. If the biopsy turns out to be benign, the red flag has to be raised, and we have to tell the patient that we cannot let you go like this. Now, what not to do? This lady had a lump here in the upper part of the breast. She was operated with a periareolar incision, so all this plane was violated. This lump was removed in pieces, and then a drain was put, which was taken out from the lower part of the breast. She was a 28-year-old lady. Turned out to be breast cancer. We could not save her breast in spite of the fact that this was the only lesion, a small 2 centimeter lesion. But this is how she was operated. The whole plane was disturbed right from upper part of the breast to the lower part of the breast. And she ultimately ended up having a mastectomy at the age of 28. Similarly, this lady, you can see a very long incision given, which is going well into the axilla. And again, there is a drain. If you see, there is a drain mark here in the lower part. Now, what happens when we do a mastectomy? Our incision does not usually cross the anterior axillary line. But in this case, because of this scar, as well as a drain mark, which is very lateral, we had to go way beyond and reach the posterior axillary line. The problem is, If this lady needs a radiation later on, a very large area has to be covered because the whole of scar needs to be covered. And if you start going posteriorly, the radiation dose that will go to the lungs, and especially in this case, because this is left side, into the heart will go up with long-term side effects. They may not come to know immediately, but there are long-term side effects of excess radiation going to lung and to heart. So if I summarize everything, then a discrete mass needs to be subjected to mammography in a 30-year-old above. A less than 30-year-old lady, maybe ultrasound first. It may or may not be visualized. If it is not visualized, go to ultrasound. If it is visualized, but there is a density remaining breast, in the remaining breast, please ask for ultrasound. If it is a fatty breast, clearly seen, only one, you don't need an ultrasound or MRI, straight away go for a core biopsy. Now, after ultrasound, you can see whether it is a simple cyst, a complex cyst, or a solid mass, completely solid mass. A simple cyst can be observed. A complex cyst needs to be examined pathologically, and a solid mass definitely needs to be. Again, on core, here they mention FNA or core biopsy, but this is a very small, very old slide. So FNA, we have stopped doing for last 10, 12 years now. If the sample is adequate, then treat appropriately. If there is atypia, inadequate sample, or there is any discordance, again, discordance, inadequate sampling, we have to be very careful of. We have to chase it and go to the next step. Now, a couple of patient scenarios. This is a 22-year-old pregnant lady, comes with a painless lump of 6 months, which is static. On examination, we find a mobile, smooth, non-tender lump, 1.5 centimeter, clinically N0, that means no lymphadenopathy. Ultrasound shows it to be a well-defined lesion, which was likely benign, but underwent core biopsy, turned out to be fibroadenoma. We are okay to observe her through her pregnancy, even if it is a slightly largish one. But if it's a very large one, we need to consult an oncologist to decide about it. On the other hand, this same lady may be 42-year-old, non-pregnant. We have to add mammogram, sometimes USG. If it is BIRADS 3, we have to again consult with the radiologist whether we can observe or we need a biopsy confirmation. Many a times we do a biopsy, turns out to be benign, we can safely observe her. If she's worried, we can do an excision. 45-year-old lady, painful lump 10 days, and cyclical pain is there. Nodular breasts are there, one side more than the other. There is a large 4 centimeter tender firm lump. Now, clinically, this becomes a little suspicious. Mammogram, BIRADS 3, because it's a small, it's a large lump, but it's a very smooth lump. On ultrasound, you find there are multiple simple cysts in both the breasts, ranging from 5 millimeter to 4 centimeters. So here in this lady, we really don't need to intervene, except we can aspirate the largest one because that is tender and is causing symptoms to the patient. With the caution that it can come back again. Most of the cyst may fill up. If the cyst fluid is absolutely clear, we don't, or it is muddy kind of thing, we don't need to send it for cytology. Only if it is hemorrhagic, we need to send it for cytology. Similar scenario in a slightly younger lady. This is a painless lump, again 2 weeks. Now we find this lump to be hard. And although it is mobile, the mammogram and ultrasound both have labeled as BIRADS 4C. So you again do a core biopsy here and turns out to be malignant. So on the left side of the screen, you don't do anything really, just aspirate the cyst, confirm that this is looking like a benign cyst material inside, you leave the lady. But here you proceed with core biopsy. So to conclude, palpable masses should never be dismissed like a benign mass. We have to reach a conclusion. Imaging must be performed before biopsy of a solid mass so that we have all the information available to us and we are not messing the breast area, breast tissue or the lump area by doing a biopsy before completing our imaging workup. In younger ladies, ultrasound is preferred over mammogram as the first investigation. And here I'm talking of a lady who is coming with a lump, who is coming with a complaint and found to have a lump. A lady who just comes for screening, we will not ask for mammogram unless she's 40. We must image both breasts and include axilla. MRI, as I said, is not of much benefit. It is more of a problem solving if mammogram and ultrasound have not shown us adequate results. Triple test, Clinical, radiological, pathological is the standard of care for evaluation of all solid lesions, whether benign or malignant, and core biopsy is the procedure of choice. Radiopatho-clinico discordance should be resolved before we let the patient go for observation. Cysts can be aspirated for confirmation of their benign nature or for patient comfort. And cytology of benign appearing non-bloody cyst fluid is not needed to be sent. Coming to pregnant ladies, because this is a common problem. Very often in pregnancy, nodularity is there. So they also pose a diagnostic challenge because of the increased breast size as well as density. Ultrasound becomes the modality of choice. Mammogram actually can be done. So with a shield. Mammogram does not give radiation to fetus if there is a proper shield put in. So mammogram is not a contraindication during pregnancy if it becomes absolutely necessary. There should be very low threshold for a prompt evaluation over observation, because we have very often seen pregnancy related cancers overlooked. I still remember very young lady in first trimester had a lump, mentioned this to her gynecologist. She examined her also and told her looks benign, which according to that clinical examination actually was small and benign like. And she said that fibroad, an ultrasound was done. It was reported as a fibroadenoma. She was told fibroadenomas do increase in pregnancy, so don't worry if they increase a little bit. But what happened was it increased much more. It increased almost 4 to 5 times, and still the patient did not bother. And she did not tell her gynecologist that this is increasing. By third trimester, it had involved almost all of the breast with lot of edema. And by the time she was diagnosed, it had already spread to bones. So something which could have been diagnosed if the patient was also a little alert, and probably alert ultrasonologist would have raised that this does not look like a fibroadenoma only. Surgery and surgical incisions have to be very well planned, keeping the future outcome in mind, because it may turn out to be malignant, and then we may mess up with the breast area in such a way that the breast conservation does not remain possible at all in that lady. And as I said in the beginning also, we should promote self-examination and clinical examination. So for a lady who is between 20, after 20 years, self-examination every month has to be done. Between 20 to 40, every 2 to 3 years, a clinical examination by an expert should be done. And after 40, it has to be annually done. And please promote opportunistic screening. I think you people have a great opportunity of doing it, and you must practice all that. Multidisciplinary management for breast lumps, even a benign breast lump, is very important. For a cancer, we obviously have our tumor boards and multiple specialists of 5 or 6 specialties, not only radiation, medical and surgical, but pathologists, nuclear medicine, radiologists, all of us sit together and discuss our patients. Thank you very much for a patient listening, and I'm happy to answer any questions if there are.
Thank you, Dr. Vedant, for such an informative, excellent talk. I would now request Dr. Shashi Kabra to give her expert comments. But before that, I just wanted to ask you 2 questions. One is that I believe that tomosynthesis is a new modality, a diagnostic modality, which is coming up, and it's going to replace mammography. Is that true? What do you think about it? And the second one is that on mammography, sometimes we find that the breast tissue is absolutely clear, but they do comment on lymph nodes in the axillary region. So, the gynecologist is left in doubt as to what is to be done next. Could you please clarify?
Absolutely. So you very rightly said tomosynthesis. Actually, tomosynthesis is a type of mammogram. It's a kind of CT scan. In mammogram, it's a 2D imaging, but tomosynthesis is a 3D imaging because it slices the breast just like a CT scan. So you will get multiple slices of the breast, and tomosynthesis obviates the need of MRI in many of the dense breasts because it will image every slice, and you will find abnormality on tomosynthesis which has not been seen on mammogram. So yes, you are very right. Tomosynthesis in times is going to replace mammogram. I did not mention few other things. Now there are contrast enhanced mammogram, contrast enhanced ultrasound. So these are newer modalities which are coming up, but largely they are not available. Tomosynthesis even in whole of Delhi probably is available at 2 or 3 places. So that's how it is. And the second question, I did mention about it in my talk, that Any radiologist commenting on a lymph node on mammogram, character of the lymph node is not right. They will say lymph nodes are seen right, but they cannot say it is suspicious or not suspicious or malignant. Sometimes they would say metastatic, even on a mammogram. They can say it appears metastatic. In such a situation, I would recommend ask for an ultrasound. And if it is suspicious, please get a biopsy done. In a very large node, we can still do a biopsy from lymph node also. If it is a smaller node, probably FNAC.
So thank you, Dr. Vedant. So what I get from this is that in case we are just screening a patient because she has a family history, so we go ahead with a mammogram and ultrasound. But in case we find a suspicious lump, then we probably ask for a tomosynthesis.
No, I would not say that. Even if there is a suspicious lump, a simple mammogram can be good. If patient can do tomosynthesis, please go ahead with it. Not a problem. Even for screening, we don't ask for tomosynthesis. We ask only for a simple mammogram. For a lady who presents with a lump, if she can access tomosynthesis, she can afford tomosynthesis, please go ahead with it. It's slightly more expensive. So if tomosynthesis is available, yes, that's a better modality.
Thank you. Thank you, Dr. Vedant Kabra. Over to Dr. Shashi Kabra.
Thank you, Dr. Divya. Excellent talk by Dr. Vedant Kabra. And he has covered all the points very nicely, and especially those points which we as a gynecologist or obstetrician are supposed to know about breast diseases and breast lumps. Because you see, he's just said that we should take advantage of the opportunity. Yes, all these patients come more to us rather than to a surgical oncologist. So we should always take that opportunity to advise them about breast screening and clinical and self-examination. There are 2-3 important points which he has said. First thing is triple test like clinical examination, then imaging, and then true cut biopsy. And nowadays FNAC is not done, and the true cut biopsy is the answer. And second thing, before 30 years, ultrasound, and after 30 years, imaging modality of choice is mammography. And one very important point he has covered, that during pregnancy, sometimes many patients come with the problems in pregnancy. So it is now clear that mammogram does not cause that much of radiation, and we can safely do mammography in pregnancy if we strongly feel about doing that with the proper shield. And I also take this opportunity to say a few words about preventive methods of breast cancer, little lifestyle management, like we should do, female should do regular exercise, should maintain her ideal body weight, and we can promote eating lots of fruits and vegetables. And then those who are smoking or those who are consuming alcohol, they should be asked to reduce the dose, and we should promote breastfeeding. That is very important, and so Dr. Sneha Buyar's important project also, that breastfeeding reduces cancer, and we should avoid unnecessary radiation and X-rays also.
A very important message, very, very important message, because in this time when most of the women are working, breastfeeding takes a backseat. And also there is a misconception that it will disfigure them, or it will make the breast more lax. I think we need to convince them to continue breastfeeding for a period of at least a year. We also need to convince them to have an early pregnancy as early as possible, given their work commitments. But early pregnancy and breastfeeding, they are two protective mechanisms against breast cancer. The contraceptive pills that we use these days have very low hormone content, and there is no proof that it increases breast cancer. But I would still prefer using other methods of than hormonal methods.
It is somewhere written that progesterone may cause higher risk for breast cancer, is it?
So the dosage that are used in current OCPs are very low, but still as a personal choice, I would not recommend OCPs to my patients, and I would tell them not to use them.
So yes, we can promote always copper T after first pregnancy.
Yeah,
that's better.
Copper T or barrier methods, other barrier methods.
I have a question.
Thank you, Dr. Vedant. It was real wonderful talk to the gynecologist, and we really appreciate what message you have given. And breastfeeding, definitely we are promoting breastfeeding, as this is our motto as a gynecologist, as obstetricians. Now go ahead.
Can I ask one question?
Yes.
Do all the fibroadenomas need to be excised?
No.
What can lead We can
There are
leave.
certain criteria.
So, ma'am, if there is a small fibroadenoma, very small fibroadenoma, especially in a lady who is approaching menopause, we don't need to remove them because after menopause, they're anyways going to go down. In a young lady, larger fibroadenoma, which is growing, most of the time needs removal. Anything beyond 3 to 4 centimeters, we have to be very cautious before observing them. But otherwise, all fibroadenomas can be observed once we have proven them to be benign by ultrasound and biopsy.
And how frequent follow-up needs to be done?
Yeah, so first 2 years, it has to be 6 monthly follow-up to show the stability of the lesion. But and this not 6 monthly mammogram, but a 6 monthly ultrasound or whichever modality has shown it the best.
Okay.
6
And
monthly for 2 years, and after 2 years we can go back to annual if it is stable.
Okay. And how the true cut biopsy is taken?
True cut biopsy is basically under local anesthesia. We make a 2 or 3 cut. It can be directly over the lump or by the side of the lump. If you are doing it under ultrasound guidance, the probe comes like this and the needle goes from the side. So it is usually at the side. But if you are doing it blind, by blind I mean I'm not taking any ultrasound guidance. I'm holding it and doing it. So please remember the standard of care is ultrasound guided. As I said, blind can be done only when it is very well palpable and the imaging has shown it to be a uniform kind of lump. If there are necrosed areas and all, it is better to do ultrasound guided. Then I'll just show you how it is. So if this is the lump, the needle goes here, we just penetrate the lump and we push the button. There is a spring load. So there are two things which come out. There is one with a boat-like shape. First, that part of the needle goes in. The breast tissue falls inside that. And then the second part goes and cuts it. So when it cuts it, that long thing that you saw in my slide,
Yes.
that long thing is cut. And this is how it is known as a core, because we are taking a core out of it, or a true cut biopsy.
Okay.
So it's a very simple procedure, can be done as an OPD procedure, but preferably done ultrasound guided.
So
just one or two quick comments if time permits, Dr. Sushila, if I can say something. Hello.
Yes, ma'am.
Yes, ma'am.
Yeah.
Go ahead, ma'am.
Yeah, thank you. Very elaborative and informative talk by Dr. Vedant Kabra. Just few things which I would like to clarify for our gynecologists. There are certain factors which are modifiable as risk factors. So definitely, as Shashi has said, our diet, exercise, smoking alcohol, and of course the use of the hormones, which are modifiable factors. Though early menarche and late menopause is not in our hand, but use of hormones as contraception and as hormone replacement therapy and breastfeeding. These are the factors which are modifiable, and we should stress on these factors to prevent or rather minimize the risk of breast cancers. Secondly, as Dr. Vedant has already stressed upon that, what are the importance of the family history and of course the family associated or genetically related breast cancers. But the total incidence of these cancers is at the most 10 to 20%. So that doesn't spare the rest 80%. And that's the reason breast cancer screening has to be a universal screening. As he has rightly pointed out, it shouldn't be, at present we are having only opportunistic screening. So it shouldn't be the opportunistic, it should be universal screening irrespective of the family history. So these are the two important messages I would like to give to our members, because and we never want to encroach upon the surgeon's field. It is their field. Once you diagnose malignancy, you have to refer timely to the expert surgeon, oncosurgeon, breast surgeon, whatever experts you have it at your disposal. But your role comes into preventive oncology, and very, very important, as worldwide the statistics says that in the Western world, you have hardly 3 to 5% of the advanced malignancy, in contrast to almost 60% advanced malignancy in India. And that's the very reason that we are having very high mortality due to breast cancer. It's not the cancer per se, but the late diagnosis and development of metastasis. So very important, responsible job for us in preventive oncology. Thank you so much once again, and thank you for giving me this opportunity.
Small point about BRCA testing.
Yes,
Your
that,
take on BRCA testing?
So firstly, let me say, Dr. Buyar Madam has made such good comments and points. It is absolutely essential to counsel your patients about preventive oncology, not only breast, but by avoiding smoking, alcohol, healthy diet, they will avoid many other cancers as well. Now coming to BRCA testing, BRCA testing is a very specialized testing and should be reserved for very small select group of patients. So if a patient has two first degree members, young members with breast cancer less than 50-60 years of age, mother or sister having breast cancer less than 40 years of age, three or more members having related cancers in family less than 60 years of age, any male breast cancer, prostate cancer. So there are certain criteria. And then any, now NCCN is National Comprehensive National Network, Cancer Network from US. They recommend BRCA testing for anybody who is less than 60. But I think that's a very broad inclusion. We don't do that, and our patients also don't agree with it. But BRCA testing has to be preceded by a very good genetic counseling. We have to counsel them, and preferably a genetic counselor has to counsel them, then subject to BRCA testing, because all BRCA tests will not give you definitive results. And then patient will say, doctor, I have paid so many thousands or sometimes even lakhs. The lab in US, which is the largest one, actually it is 3 lakhs. In India, you will pay anywhere between 25 to 50,000. And then you don't get a conclusive result. So we have to prime them, we have to counsel them, and you have to make them ready that, okay, you really want to go ahead with it, you want to know the risk, only then you go ahead with it. And very select group of patients will have. Now again, BRCA testing is not only restricted to BRCA1 and BRCA2 now. We are now going for multi-gene testings, because BRCA1 and 2 is involved only in around 80% or 85% at max of breast cancers which are genetically transmitted, which are hereditary. Remaining 15 to 20% are because of some other genes. And if we do only BRCA1 and 2, we will miss other genes. And then there are multiple ways of doing BRCA testing. There is something called MLPA, which ideally should be done always. So it's a more complex procedure, and I would personally request that please involve a genetic counselor before you ask for BRCA test.
Thank you.
Thank you. Thank you.
Any more questions?
Thank you very much. Dr. Divya, you can take over.
Dr. Shashi Kabra.
Yes, Dr. Divya.
For giving this opportunity. Thank you, Dr. Pankaj.
Thank you, the multidisciplinary.
Can't hear you, Dr. Divya.
Ma'am. Thank you, Dr. Vedant Kabra, for your excellent talks. And the discussion was very informative also. I'd now like to thank our sponsors, the DGF North and Multidisciplinary Committee of DGF of AOGD and the FOGSI Committee of Breast Cancer Prevention. Thank you, Dr. Sneha Buyar, for being with us throughout. I would like to ask Dr. Shashi Kabra to take over.
Yeah, thank you, Dr. Divya. Thank you for moderating and organizing it so well. And thank you, Dr. Sushila Gupta, ma'am. Thank you, Dr. Sneha Buhar. You were there with us for the whole time. And thank you for giving this opportunity. And Vedant, thank you so much. It was an excellent talk.
Thank you.
And Dr. Sushila, it was a complete, elaborate talk on diabetes. Very good, gestational diabetes mellitus. You covered everything. And we really enjoy the CME.
Thank you, Dr.
Thank you so much. Thank you everyone.
It was wonderful talk, Dr. Vedant. Dr. Sneha, thank you once again. Thank you, Shield personnel, for giving this opportunity and providing this platform. Thank you, everybody.
Thank you very much. I must thank you for inviting me to this virtual platform. And Dr. Sushila, you in fact took over the whole subject of diabetology so well, and you covered everything excellently.
Thank you.
Hats off to you, ma'am.
Thank you. I tried. I had to rush to complete the things.
No. We were just listening to you. We were in no hurry.
Thank you. Thank you once again. Field person is there. Dr. Prachi, Dr. Sarita, someone is there.
Thank you, Dr. Shashi.
Yes, ma'am. Yes, ma'am. I'm there, ma'am. Nice session, ma'am. Thank you so much, ma'am.
Yeah, thank you, the sponsors also.
Should we wrap up?
Yeah.
Mr. Prachi?
Ma'am, Prachi ma'am is not here. This is
Sarita?
Chitrakla from Shield, ma'am.
Sarita, yes, Sarita ji?
Yes,
Can
ma'am.
we-
Yes, ma'am.
Yes.
Yes, ma'am. Yes, ma'am.
Anything else to be discussed?
No, ma'am. Everything covered, ma'am.
Okay. Thank you so much.
Great
Thank you.
session, ma'am.
Thank
Great
you.
session, ma'am.
Thank you,
Thank
both of
you
you.
all.
Thank you so much. Bye-bye.
Bye.
Bye-bye,
Bye.
ma'am.
We'll see you again.
Sure,
Yes,
sure.
yes. Keep on meeting. Stay safe. Stay
Yes.
healthy, stay safe.
Stay safe, stay healthy.